how much intuition would you say you have to use in this compared to just knowing, concreteness and paying attention to tangible? Like, how much intuition would you say is required?
I think it's a good amount of looking at what's before you and kind of using a gestalt and getting the big picture and moving from there. I mean, dermatology is so descriptive, and it's a huge thing that's emphasized in residency is learning how to describe what you see. And it's not, you can't necessarily like just memorize pictures from a textbook and then be able to diagnose every patient you ever see. A lot of it is kind of figuring it out as you go and while you're looking at the patient in the room. So I would say it takes a good amount of intuition and also being okay with blurred lines and less than clear diagnosis, because it's never going to look exactly like it does in a textbook or on a flashcard. So yeah, I would say a fair bit.
Would you say it's relatively balanced on the amount of intuitive versus concrete awareness that you need to have in dermatology, or do you think one's more outweighing the other?
I think that there is some leeway and creativity in terms of how you can treat someone, but there's definitely accepted approaches and not accepted approaches. And that's where the concrete knowledge comes in. Like, you cannot just go off the rails doing your own thing for something like psoriasis. I mean, there are things that have been tested and studied and know work. So I think for sure there's a balance there between intuition and concrete knowledge.
So there are two types of intuition. Yeah, the extroverted and the introverted ones, introverted forms of intuition. So starting with the extroverted one, this is about seeking abstract meanings, seeking different possibilities, predicting a wide variety of, I guess, hypotheticals. So kind of like what I said about extrovert sensing, where it's you're looking outside in the external to look at concrete data. This is similar, except when it comes to abstract data. So instead of focusing on a specific prediction or a hypothetical, you're branching out and being, oh, it could be this, or it could be that, this possibly, this possibly. Basically, a good example of that would be like, differential diagnosis, trying to think about every single possibility possible for a specific thing.
But what I've seen so far in DC, which is where I'm training, maybe 25% of patients, you don't know exactly what something is. And in that case, you would biopsy. And so a biopsy is necessarily something that requires a differential diagnosis. So you're usually a pathology with at least 3 things, and you might have one at the top of your list that's probably going to be the right answer, but creating a differential is important, because if you are biopsying something, the point is that you don't know what it is by just looking at it, but you better have a differential available. If you already know what it is, then you shouldn't be cutting on someone's skin. So I'd say that's like the most frequent use of that kind of thinking process.
Yeah, of course this is going to depend, but like, how often do you think like, would you say more often than not, when you biopsy something, is it more likely to expand your realm of, possibilities of diagnosis, or is it more likely to narrow it down? I mean, of course it depends, but like, in your experience, which one do you think it tends to be?
How wise you are in your biopsying. So there are people who probably biopsy more than they should. And in that case, it's going to expand your differential, because you might biopsy something without any kind of clear picture or reasoning why you're biopsying. If you are using it wisely and with good judgment, it should definitely narrow your differential, because you should already.
That's the goal, right?
Right. Exactly. Narrowing it. But if I were to biopsy something random on someone's skin, even just a random location where there's no apparent lesion, you could probably find some kind of pathologic description that's, maybe describing normal skin, but we found this random thing that you didn't expect. Yeah, that could happen if you don't have a reason to biopsy. But if you have a clear picture of kind of where you want to go with your diagnoses and what the options are, then it should definitely narrow it.
Introvert intuition. So kind of like how extrovert intuition was looking at a wide variety of different possibilities. Introvert intuition is more about narrowing down those possibilities and focusing on one or fewer predictions, and going more, I guess, looking more long-term in those predictions, going more in depth with fewer predictions. So what are some tasks that require you to do that? I mean, obviously, like when you're diagnosing someone and you're narrowing down your differentials, and a biopsy helps with that. But is there anything else, any other tasks that that help with narrowing down your realm of possibilities and being more focused in your predictions and conducting like understanding of like long-term prognoses and whatnot?
Totally. I think response to treatment. So if you okay, you think you have your diagnosis and you start a treatment and the patient either responds poorly or doesn't respond at all, at a certain point you have to go back to the drawing board and reconsider the initial diagnosis. It's not, the assumption shouldn't be, oh, they're just not responding. And you should be willing and open to going back to that drawing board, and having the humility is important to, come to the patient and reconsider what you were initially thinking. So I think, yeah, that's a huge one.